Good morning. My name is Skyler Miller. I am a part of Milliken Group number 5, and our final project presentation will focus on mental health within the United States. Using the data that we had extracted from the dataset, we knew there were some important questions that we could better understand throughout our investigation of mental health trends within the United States. These questions included things like how does mental illness prevalence vary across different states as well as age groups? Are there certain states that have a higher or lower access to mental health treatment? Where is the unmet need for mental health care most concentrated, and is that unmet need improving over time? What roles do insurance, income, employment status play in access to health care? And finally, what potential impacts did the COVID-19 pandemic have on mental health trends? Mental health is a very important topic to better understand because these mental health conditions affect millions of Americans each year. And if these mental health conditions are left untreated, it can lead to multiple types of burdens, whether it be personal, social, or economic. And additionally, understanding these trends are crucial for taking effective action by policymakers and decision makers across the country. With the dataset that we used, we found that a little bit under 23% of US adults aged 18 and older experienced any mental illness or AMI within 2023, and that equates to over 58 million Americans. Now we're going to dive a little bit into the dataset that we used, which was the National Survey on Drug Use and Health, or the NSDUH. This is a nationally representative survey that's conducted annually by the Substance Abuse and Mental Health Services Administration, or SAMHSA, and it's a primary source of statistical information among U.S. civilian, non-institutionalized population, age 12 or older, and we decided to focus on the age groups 18 and older. We use this because it provides a reliable and comprehensive insights into behavioral health trends over time as it's carried out each year. And it allows for analysis across various demographic groups and U.S. geographical regions on a state level. It focuses on substance abuse, substance use disorders, mental health issues, and the receipt of treatment. And this data comes from either face-to-face interviews within people's homes, or since COVID-19, they focus more on web-based interviews. And the survey covers residents from households, persons in non-institutional group quarters like shelters, boarding houses, or dormitories, as well as civilians living on military bases.
Here's our Power BI data model. Most of our tables are standalone and pre-aggregated. They represent separate views like income, insurance, or employment, and don't share common keys. Because of that, we didn't create relationships between them. The only exception is the table on the right, which tracks any mental illness and received mental health care by age, year, and state. That one is connected to a shared dimension table so we could slice it by different filters in our visuals.
I focused on a subset of the data that gave key metrics into the prevalence of any mental illness, or AMI. And this is defined as a mental, behavioral, or emotional disorder that excludes the developmental and substance use disorders. In the Power BI visual, we see the age group of 18 plus and any mental illness trends within the years 2018, 2022, and 2023, with the highest ranking states on the left side of the graph being Utah, Oregon, and West Virginia, and some of the lower ones on the right side of the graph, such as Hawaii, Florida, and New Jersey. We wanted to break AMI down by age group and see if there was some sort of a generational divide. And with the data that we used, we found that age group 18 to 25 reported the highest rates of AMI within all 3 years, 2018, 2022, as well as 2023. We also found that age 26 and older reported the lowest AMI within these age groups. Next, I wanted to focus on AMI within a filled map visual, just to see how states compared to each other on their AMI levels. This is a good insight into the mental health prevalence and how it can vary significantly by state or by geographical region, suggesting that there might be regional factors that play a role, such as the local economics that they experience, the weather, or culture. Within the filled map visual, blue represents the lowest AMI, yellow/orange color is representing the median, and red is showing the states with the highest AMI within that year. Now in 2018, Utah is the only explicitly red state, but when we compare that to the post-COVID-19 map, we see some stark differences. In the 2022 filled map visual, we find that fewer states are blue, which represents the lowest AMI, and that suggests that COVID-19 may have played a role that negatively affected mental illness. We also see that the Midwest and Pacific Northwest experienced higher rates of AMI on average when compared to the 2018 map. Lastly is a 2023 field map visual. And this year we find that AMI goes down a bit overall, but there are still a few red states. We do see, however, that there are more blue states, primarily those that are on the eastern and southern coastlines. On average, the Midwest and Pacific Northwest do still have higher rates of AMI similar to 2022, so perhaps their geographical location may affect their mental health, whether it be a lack of sunshine, increased types of certain weather, or even the more rural living that is more commonplace within certain areas of these states.
As we look at this slide on access to mental health care, we see significant variation in the percentage of people receiving treatment across states. At the top of the chart, Vermont, the District of Columbia, and Utah consistently show some of the highest rates of mental health care utilization. This may be due to a combination of factors such as better funding for mental health care programs, more progressive policies around mental health access, and a higher concentration of providers per capita. For example, Vermont has a long-standing reputation for prioritizing community-based health services, and DC benefits from being a relatively urban, policy-driven area with more accessible care infrastructure. On the other end, states like Texas, Florida, and Hawaii report some of the lowest percentages of people receiving care. These states face a variety of barriers. In Texas and Florida, mental health funding has historically lagged behind national averages, and provider shortages, especially in rural areas, can make access difficult. Hawaii presents unique logistical challenges due to its geography and limited in-state resources, which can make it harder for people to find consistent care. So this chart isn't just about numbers, it's a reflection of how state-level policies, funding decisions, and infrastructure all shape real-world access to mental health services. This slide shows the percentage of people with unmet health care needs by state and year. What's immediately clear is states like New Mexico, Nevada, and Hawaii continue to struggle with high levels of unmet need, likely due to a combination of provider shortages, geographic barriers, and underfunded services. In contrast, states like Maine, Massachusetts, and Vermont have some of the lowest levels of unmet need, suggesting more robust access to care and better support systems in place. What's encouraging is the overall trend. Unmet need has steadily declined across most states from 2018 to 2023. That shows progress, likely tied to expanding telehealth, increasing public awareness, and policy efforts aimed at improving access.
Given the unmet needs that we have seen, our investigation turned to why these gaps exist. So we started with two of the most common assumptions. The care is determined by how much money you make and where you live. On this slide, we tested that hypothesis. So on the left, we have a chart breaking down who have received mental health treatment by annual family income. And on the right, we see the same breakdown by location, whether someone lives in a large city, a smaller one, or a non-metro area. These findings were quite surprising. As you can see, the percentage of people who have received treatment is remarkably consistent across all income levels. Someone in the lowest income bracket was just as likely to have received care as someone in the highest. And similarly, the chart on the right shows that living in a large metro area versus a non-metro area had no significant impact on whether a person received treatment. This told us that while financial and geography barriers are certainly real, they might not be the primary drivers for the disparities we have seen at a national level. After seeing that income and location were not strongly correlated with received care, we continue our investigation by looking at other factors, health insurance and employment status. And there, the results were much more definitive. Looking at the chart on the left, the difference between those who have health insurance and those who don't is significant. The green bar representing received health treatment is much larger for the insured groups, and that confirms that insurance coverage is a critical factor to care. This chart on the right, which breaks down access by employment status, also reveals interesting patterns. We found that mental health treatment are generally more accessible to those who are insured and those who are either working part-time or at the underage category. This is an interesting finding, as it suggests that the structure of insurance plans and the flexibility of employment play a very critical role in a person's ability to get those help. Now we have established that an unmet need for care exists, but why does it exist? Is it because the healthcare system is failing to provide those, or is it something else? And here we analyze the population of individuals with an untreated mental illness and ask a simple question: did they try to get help? And the results are interesting. The vast majority, that's over 90% of this group, fall into the light blue portion of the pie chart. These are the individuals who didn't receive mental health because they did not seek or think they should get treatment in the first place. It suggests that the single biggest barrier to closing the gap isn't necessarily a lack of doctors or facilities. Instead, it is a gap in mental health awareness. Only a small fraction, about 8%, represent people who knew they need help and reach out for it, but they were unable to receive it. This tells us that our efforts must focus heavily on the public education to help those people recognize when they need the support. Our earlier analysis clearly showed a significant year-over-year increase in mental health illness from 2018 to 2023. This led us to a question: how many did the COVID-19 pandemic contribute to this trend? To begin answering this, we look at data where people were directly asked about the pandemic's impact. As you can see, a clear majority felt an impact. If you combine the orange and purple sections, you will find that over 50% of people surveyed have that the pandemic negatively affected their mental health, either a little or some, or quite a little bit. Only 44% of those who responded felt it has no impact. So this finding provides strong evidence that the pandemic was a major stressor that directly contributed to the decline in mental health well-being that we have observed in the other data. And to further understand the pandemic's impact on mental health, we also examined its impact on related behaviors like substance use. So this slide continues the investigation by looking at self-reported changes in alcohol and drug consumption. The pie chart on the left focuses on alcohol, while the majority of respondents, about 59%, said they drank about the same amount. A notable 28% reported that they drank a little more or much more due to the pandemic. This suggests that for nearly 1 in 3 people, that increased alcohol consumption was a response to the stress of the pandemic. And the chart on the right showing the drug use tells a more complicated story. Again, most people, about 52%, reported their usage stayed about the same. However, we see a larger group of people have decreased their use other than increased it. So these behavior shifts, particularly in the increase of drinking, provide another layer of evidence showing that pandemic has created significant lifestyle changes. And next, we turn to one of the most critical questions in our research, the relationship between received mental health and suicide. The chart compares 2 groups from 2023. So on the left is those who did receive mental health treatment, and on the right is those who did not. The colored bands at the bottom represent the percentage of people in each group who reported experiencing some form of suicidal behavior. Now, it is very important that we interpret this chart correctly. So at first glance, you may notice that the group that received treatment shows a higher percentage of those behaviors. This does not mean that the treatment is ineffective, but on the opposite, it shows people who are experiencing the most severe distress are the ones who reached out and received professional help. And therefore, the finding here is that mental health treatment is effectively reaching and serving the people with the most severe needs. So this proves how important access to care is, especially when it comes to supporting individuals in crisis.
To wrap up, we found that mental health treatment rates have steadily improved from 2018 to 2023, but despite this progress, around 17% of people who need care still aren't receiving it. Younger adults, especially those 18 to 25, continue to report the highest levels of mental illness. We also saw strong geographic differences, with states like Vermont and Massachusetts consistently doing better in access and treatment. The good news is that overall unmet need is trending down, which points to a slow but positive shift in awareness and care availability. Based on what we found, one-size-fits-all policies aren't enough. States need tailored strategies that consider their specific barriers, whether that's geography, provider shortages, or population needs. We also learned that the awareness plays a huge role. A lot of the unmet need isn't from lack of resources, but from people not seeking help. Expanding telehealth and flexible care options, especially in rural states like New Mexico and Nevada, could make a big difference. And finally, future data should capture why people don't get care, so that policies can target those root causes more effectively. That wraps up our presentation. Thank you for your time and attention. On the next slide, you will also find our list of references.